So in this presentation, we will spend time talking about one of the newer therapies, CAR T-cell therapy for heavily pretreated patients with multiple myeloma. So I'd like to present a patient, a 57-year-old gentleman diagnosed 24 months previously with the stage 3 multiple myeloma. Cytogenetics were classified at intermediate risk. He received RVD therapy and achieved a VGPR. After that, underwent high-dose melphalan with autologous stem cell transplant. The laboratory findings right now indicate a hemoglobin of 11.4, a creatinine of 1.0. The M spike had gone up from 0.6 grams per deciliter to 1.2 and subsequently to 1.5 grams per deciliter. The patient reporting feeling tired, continued to function quite well despite these facts. And he was started on therapy with carfilzomib, lenalidomide, and dexamethasone. And after 6 cycles of therapy, achieved a partial response. He was subsequently hospitalized due to a pneumonia event and complained of increasing back pain, fatigue, and weakness. Lab work was done again, showing M spike of 2.1 grams per deciliter, beta-2 microglobulin elevated at 6.2 milligrams per liter, albumin quite low at 2.1 grams per deciliter, and a very low creatinine clearance of 32 milliliter per minute. He was now started on daratumumab with pomalidomide and dexamethasone and achieved stable disease after 3 months on this treatment regimen. In August of 2018, imaging was conducted with the PET-CT showing FDG uptake, revealing also destruction by CT, so these are osteolytic lesions. Also, a bone marrow biopsy has been conducted showing 70% plasma cell infiltration, and there are abnormal appearing plasma cells confirming CD138 positive light chain restricted plasma cells. The ECOG status was determined to be 2. So I will spend a few minutes talking about one of the new CAR T-cell therapy protocols. This is the BB2121 that recently was presented at the ASCO meeting in Chicago. Anti-BCMA CAR T-cell therapy in patients with relapsed refractory multiple myeloma. This is an update from the multicenter phase 1 trial. In brief, as I pointed out, is for patients with relapsed refractory myeloma. At this ASCO presentation, the update focusing on safety and efficacy appropriately, and there were 43 patients included in this analysis. Patients had received 3 or more prior lines of therapy, including a PI, an IMiD, or they could be double refractory. And for the purpose of the phase 1 trial, the requirement was 50 or more % BCMA expression on the plasma cells. Patients received 1 infusion of the BB2121 following lymphodepletion with the fludarabine and cyclophosphamide given for a total of 3 days. Here are some of the safety data. As you can see on this slide, the total CRS rate was as high as 63%. Focusing on grade 3 or higher, it was 5%. The neurotoxicity was overall 33%, and for grade 3 and higher, 2%. And the classical hematologic manifestations for adverse events, as illustrated by this slide also. The BB2121 safety was manageable at doses up to 800 10⁻⁶ CAR T cells. Most of the CRS were grade 1 and 2. Tocilizumab and steroids were used infrequent. That was 21% and 9% respectively. There were 2 grade 3 CRS events, and these resolved importantly within 24 hours. There was 1 grade 4 neurotoxicity event that was reversible. No additional events during the expansion phase. So let's take a look here at the responses for the evaluable patients from this presentation. If we start looking at patients who received 50 million cells, and that's the left column, the overall response rate was 33%. For patients who received 150 million cells, it was 57%, and patients who received more than 150 million cells, they had a 95.5% overall response rate. The complete response rates was 0, 43, and 50% respectively. And if you look at the median duration of response, 1.9 not estimated and 10.8 months.